So here we see the latest figures on the growth in cases in several European countries. We notice the direction is up in Germany, Belgium, Spain, the United Kingdom of course, but France now over 30,000 confirmed cases per day, so dramatic increase there in France. And when we look at this on a per capita basis, we actually see the United Kingdom lower down. Netherlands and France actually pretty similar. So Netherlands similar growth rates to France. But Belgium and the Czech Republic are going sharply up. And what's more, there's no great obvious indication that that is levelling off in any way. Welcome to this video, of course. Always great to have you along. Now, the next graph I'm going to show you is really quite interesting and quite a powerful graphic, I think. So let's go on to this one here. This is the one we've been looking at, cases per million. And then we go on and include the United States. So going back, then with the United States. And we see the United States figure is much lower per capita than these European countries. Doesn't mean to say there's not a huge problem in the United States because of the large population, much larger population than any of these European countries, of course. But it does show how significant the rate of increase in these European countries is. So in this video, I want to look about risk assessment or risk stratification. How can you work out what your personal risk is of becoming severely ill or dying from COVID-19? And also you might want to use this tool to assess the risk of your family members and significant others round about you. And I want to look at the problem in Europe in a little more detail. And then we think about the vaccines, which are looking remarkably hopeful now. And putting these ideas together, I think the case I'm going to try and make is that vulnerable people who score high on the risk assessment scale, in Europe especially, and also in the States, because there's so much disease around at the moment, really need to think about guarding for the next 6 months. Then we're going to get vaccines and things are going to be dramatically better. So this next 6 months is going to be absolutely critical to get the death rate down. And of course, I could be talking about the death rate of you, me, or members of our family. How can we be armed with the necessary information? Now, there's several risk calculators we can use, but this one is simple, easy to use. It's from the British Medical Association. Now, the British Medical Association are very keen to point out that this is to assess people's risk to work in the medical field. They're not saying it's applicable to everyone, and they put in legal disclaimers and all sorts of things. But the point is, the detailed risks are going to be the same, whoever you are, by virtue of your humanity. So because it's from the British Medical Association, I think it's probably quite a good one to go with. So we're going to run with this for now. More useful tools, more precise tools, probably algorithm based, are going to come out. But this is quite a useful one for the time being. So let's go through it. I'm sure you find it interesting. So it's based for work-based assessment. I actually filled this out myself a good few months ago, or a similar one, a less sophisticated version of this. Model does not incorporate in external risk factors. So that's a good point. So this is about the risk for the individual. So we normally think about the risk for individual, but what about the circumstances they live in? Are they in what might be called a high-risk multi-generational household, for example? And we also know, and it's not included in this tool, and it's not entirely clear why, but people with mental health difficulties also do seem to have an increased risk for getting more severe COVID. So many things we don't know yet, but I think two useful provisos to put in there: higher household risk members and mental health issues. And we have talked about ways on this channel to try and manage mental health issues and even sometimes improve them, hopefully. Now, the other thing that is still remarkably unsure is pregnancy. People seem to be very reluctant to go into print to comment on pregnancy. Let's see what they've said. So remember, this is the British Medical Association. And this, I only downloaded this yesterday. There is currently insufficient data to make any meaningful assessment about the risk of COVID-19 to either the mother or the unborn child. So they're still very much sitting on the fence there, aren't they? Indeed, this pandemic is not yet 9 months old. Well, it's just 9 months old, isn't it? Is what they're saying. Until more information is available, we would recommend that all people who are pregnant be regarded as high risk and offered the option to shield in terms of the work situation. So what the British Medical Association is saying here, for nurses and doctors, for example, frontline workers, women that are pregnant should be given the opportunity to shield, purely because we don't have enough data to say it's safe. Now, having said that, I don't know of any convincing data that indicates pregnancy is high risk, but this is the British Medical Association and they're simply saying they don't know. So on this channel, of course, we only go by the published data, so that's what we go by. Now, they stratify risk. Less than 3, low risk. Medium risk, 3 to 5. Greater than, equal to or greater than 6 is high risk. And what you do is you go through this score and you add points. So are you or the person you are collecting information about, in what age category are you? So I'm in my early 60s. I'll get a 2 for that. But you can fill it out for your significant other or yourself. So far I've scored 2. Sex at birth. So I was born a boy, so I get a 1 for that. If you're female, you don't get anything for that. So you can see already I'm up to 3. 2 for my age, 1 for my gender. So I'm up to 3. So I'm at the top of the low risk already, almost into the medium risk before we go on to comorbidities. Now, ethnicity. So basically white Caucasian, 0. Black African descent. Now, this is African Afro-Caribbean. Now, this is for these ethnicities living in the UK. But the data seems to be accurate for the US and other European countries as well. So markedly different from Africa. But this is for people living in the UK. No mention that dark skin produces vitamin D more slowly. They don't mention that. They don't mention vitamin D levels anywhere, unfortunately. But Black African descent scores 2. Now, that's all the information they give. So clearly, now we have many people who might have a Caucasian mother and a Black African descent father or a grandfather. It doesn't give the proportion of risk for varying genetic proportions. It simply says Black African descent, 2 points, so you'll get 2 points for that. Indian Asian descent, 1. Filipino descent, 1. Others including mixed race, 1. So if any of those apply, you would add that up, because I'm currently up to 3, aren't I, for my risk. Now, diabetes, type 1 or type 2 diabetes. Now, we have mentioned this before. Type 1 diabetes typically, not always, but typically is juvenile onset. It's due to normally autoimmune destruction of the beta cells in the pancreatic islets of Langerhans, the cells that make the insulin. So type 1 is an absolute insulin deficiency, and without insulin these people would die. Type 2 can be caused by insulin deficiency, but very often it's caused by insulin resistance and typically occurs in older people, has been called maturity onset diabetes, although these aren't terms we use anymore. Typically people with type 2 diabetes will moderate their diet. They will take oral hypoglycemic medication to lower their insulin, and after time they probably will go on to need insulin as well. So type 1 or type 2 grouped the same. Now you get 1 score if you are a type 1 or type 2 diagnosed diabetic with well managed disease, and you score a 2 if it's poorly managed disease. And they actually define how well the disease is managed. So this is complicated disease here. This is what they call complicated disease. It scores 2. Complicated diabetes equals presence of microvascular complications or HbA1c greater than 64 millimoles per mole. I'm not going to explain this in great detail, but basically microvascular complications are when in diabetes you can get as a complication disease of the very small blood vessels, not the large arteries, but the small blood vessels, particularly the arterioles and the capillaries. Damage to the small vessels, and that can cause things like retinopathy and blindness and renal problems, for example. Particularly, it can cause renal problems. And this HbA1c, that is the long-term measure for about 6-7 weeks, 6 weeks I think we normally say, of the average blood sugar level over 6 weeks. So this means that people who've had a high blood sugar level for an average of the last 6 weeks are more at risk. So clearly we're seeing here, and this is a remarkably important point, that the better they manage the diabetes, the lower the risk. Poorly managed diabetes, higher risk. So important to correctly manage diabetes. So that would score 1 or 2 there. Obesity. Now we normally say obesity is equal to or greater than 30, a BMI of 30 kilograms per square metre of body surface area. So this is really quite obese. One is really people that are really quite obese. But again, it's a simplification because presumably there's a sliding scale. So I'm a bit overweight, so that will carry some higher risk. More overweight, greater risk. More obesity, greater risk. But that's what they're saying. This is the scale they're using, so this is what we go with. Now, presence of previous cardiovascular disease. Angina is poor blood supply to the heart muscle. Previous MI, that is myocardial infarction, that is a heart attack. Stroke, that's a cerebrovascular accident to the brain, or a cardiac intervention. This would be something like having a stent fitted or having a coronary artery surgery. Any of those, that scores a 1. Heart failure is where the output of the ventricles of the heart, the pumping chambers of the heart, are insufficient to meet the metabolic demands of the body, and the heart is not working adequately. Can also be associated with the presence of fluid in the tissues, which is called edema. So that is heart failure, and that has a higher risk. That is graded as a 2. So asthma, 1 for asthma, for increased risk of serious disease and death. Non-asthma chronic pulmonary disease. So this is things like bronchitis, emphysema. COPD is an umbrella term, and it can include asthma, chronic asthma, and bronchitis and emphysema. But here we're dividing the two. We're not using COPD. We're saying chronic lung disease, which is not asthma. Higher risk for bronchitis and emphysema. Either of the above requiring oral corticosteroids in the previous year, an extra score. So what happens is asthma is largely caused by inflammation, so we give steroids to dampen down the inflammation. So here we have people that have had steroids in the past year. Steroids are immunosuppressives, but it also means the disease has been more severe. So probably a bit of both there, probably a side effect of the medication and indicating more severe disease. People with cancers, active cancer, 3, malignancy, cancer in remission, 1. Okay, so thankfully I haven't scored any more on that page, but you may have done or your relatives may have done, unfortunately. Final factors, rheumatological conditions. So this typically affects the joints, although you can get rheumatological features in other organs as well. Actively treated, and again we tend to treat this with immunosuppressing drugs. So that could be a factor there. An immunosuppressant therapy given for any reason. So for example, someone who's had an organ transplant, for example, might be on immunosuppressant therapy. Quite a significant extra risk. So my risk has stayed at 3. So my risk is here. So I'm between low risk and medium risk. But do work out your own level of risk. Now, if you want more on comorbidities, there's an awful lot of data to choose from, and I haven't got the link there, but that links us through to the Centres for Disease Control if you click on it. And that goes through all the different conditions for the Centres for Disease Control from the United States. You can look up any condition you have or a relative has, get information on it, and it gives specific advice on what to do for the American constituencies. So plenty more information on that. Just click on that, and very detailed information there. And as normal for the Centres for Disease Control, the information is very accessible. It's easy for any moderately intelligent layperson to read, and they'll make sense of it. Now, having said that, the American data, the American data is well presented. The American CDC, the European CDC, dear me, it's full of data, but it's really quite hard to access. So you click onto it, and it's really quite hard to get a handle of what they're saying. They expect a lot of previous knowledge. I struggled to understand quite a bit of it, but I have got some stuff from it here. So this is the European Centre for Disease Control. Data for week ending 42, which we have complete data from the 18th of October. And this is the European Economic Area where they collect this data from. So it's all these countries here. So this is actually quite a good test if you can do these. So I know that one's Norway, that's not included. Now the United Kingdom is included in this data. Scotland, England, Wales, Northern Ireland included. The Republic of Ireland, of course, is included as part of the European Union, and all these other countries. You can freeze frame that and see if you can name them all. I'm just wondering if I can do it, but anyway, there we go. That's the Czech Republic, I think, where we were looking at the other day recently in the high figures. Anyway, moving on. So that's the area it's looking at. Now, sustained increase over 2 weeks in 28 countries in this area. Right, so here we're saying there's been a sustained increase over 2 weeks in 28 countries. There's no question we're well into a second wave now in Europe. And they're defining that as at least 60 cases per 100,000, but the problem is the trends aren't good, as we have, as we've already noted. The trends aren't good. So all these countries, 2 weeks sustained increase now. Austria, Belgium, Bulgaria, Croatia, Cyprus, Chechnya, Denmark, the list goes on. And it does include the UK. So Sweden and the UK at the end. So all of these countries, dear me, sustained increase over 2 weeks now. Now, that's one thing, but what about the higher risk people? Well, sustained increase in the last 2 weeks in 16 countries in the over 65s. So these are countries where the older population has had a sustained increase, and we know this is going to feed through into hospitalisations. We know this is going to feed through into more deaths. So this is where we're at with that at the moment. Austria, Chechnya, Denmark. The list goes on, ending in Spain and Sweden. So these countries have more cases in the last 2 weeks in the over 65s. Therefore, these countries will all have more hospitalisations, will all have more deaths over the next few weeks. Now, these countries, I'm not going to throw any more data at you after this, these countries have had at least a 3% increase in positivity rates over the past 3 weeks, over the past against the previous week. I think basically it's an increase. Weekly test positivity of at least 3% or had an increase against the numbers in previous weeks. Right, so there's been higher than 3% in the past 2 weeks, or the trend is upwards, is what this is saying. And again, upward trend in positivity tests in all of these countries. And we know that the increase in the number of tests, the percentage of tests coming back positive, is a good indicator of how much community spread is going on. So in all these countries, quite a lot of community spread. Therefore, we would anticipate that the lines in these countries will go up more steeply, is what we are saying. So do look at the European Centres for Disease Control. Lots of great information there, but nothing like as accessible as the American one, I must say. They really need to get their act together on public accessibility. So where we're at, we've got this problem of increasing cases. We've seen that, and we know that some people are at much higher risk. And this is going to be the case until we get vaccines. So really, until we get the vaccines, a lot of people that you know might seriously want to consider guarding measures over this winter when there are going to be more cases and we believe more community spread. I think we've given the evidence for that now. So let's give the good news on vaccines, or some good news on vaccines. Now, this is Matt Hancock, the UK Minister of Health. Actually, I'm a bit confused. He's certainly Minister of Health for England. He seems to have something to do with the other countries as well. It's hard to tell with the division of the UK government at the moment. Vaccines, early months of next year. And we can assume that Matt Hancock has got that straight from the horse's mouth. Now, the Oxford AstraZeneca vaccine, AZD1222, we're making in the UK 30 million doses now. 30 million doses being made now, waiting for the results of the trials. But as soon as we get positive results from the trials, we get 30 million doses of vaccine out very quickly. If the trial proves that the vaccine can't be used, they're going to have to get chucked out. But they're ready. They're ready. Or getting ready now. First rollout, main rollout first half of 2021. So most of us will probably be getting vaccinated next April, May. February, March, April, May, June time. It will take time. It's a rollout. Some people might be vaccinated before New Year's Eve, he said. That means in 2020. Now, this vaccine, the Oxford AstraZeneca vaccine, the immune response is similar across all age groups. Now, that is remarkably good news and also pretty surprising, because typically vaccines don't work as well in older people. Typically, older people don't develop as good an immunological response when they're exposed to the actual disease compared to younger people. But this vaccine seems to have a similar immune response in all age groups. That is amazing and very welcome indeed. So remarkably good news there. Strong immune response in the elderly, strong in italics, it's their direct quote. Encouraged to see immunogenicity response were similar between older and younger adults. That's a direct quote from AstraZeneca. So this is remarkably encouraging. It looks like this vaccine is not just going to work for fit 18 to 30 year olds. It looks like it's going to work for everyone, which is really very, very encouraging. Now, lower levels of side effects in older people than in younger people. So again, good news for older people who are most at risk. Because the elderly usually have an immune response. So the influenza vaccine, for example, it was found out, I can't remember when, but it was a few years ago, that basically it wasn't producing an immune response in older people, and the older the less the immune response, because older people have a less active immune system and don't generate as good an immune response. And adjuncts had to be added to it to try and improve the immune response in the elderly. But this new COVID vaccine doesn't seem to be like that. It seems to work in all age groups. So good news and surprisingly good news. More good news, as well as generating antibodies, it also generates memory T cells. That is remarkably good news. Now, how long will these antibodies last? A matter of months. How long will these T cells last? If you meet someone who says they know, they don't. We don't know. Let me tell you two things we do know. The 4 types of coronavirus that cause common cold type features, coryzal type features, the immunity in those from those only lasts for a few months, perhaps not more than less than a year. And you can be infected with the same viral type again. So not looking good from that point of view. But SARS coronavirus 1, people that were infected in 2003 still have the memory T cells now, 17 years later. And if we test again in 10 years' time, I think they'll probably still have the memory T cells 27 years later. Of course, we don't know that, but we do know they're still there after 17 years. Impressive. And from what I know about the current virus, it's more similar to SARS 1, the 2003 outbreak, than the other one. So I'm hopeful these T cells will last. And what these T cells will do these memory T cells, if there's a cell here which is infected with the virus, so that's a cell that's infected with the virus, these memory T cells will divide. So you'll have one memory T cell there that recognises the presence of the virus. That will divide into 2, that will divide into 4, each one of those. You see, each one will divide, then you'll end up with 8. Then you'll end up with 16 and produce billions of these things. And these memory cells will differentiate into these clonal expansion cells, which are the same as this one. And one of these lymphocytes will come along, one of these memory T lymphocytes will come up to the infected cell, and it will deposit chemicals on it that will kill the whole cell, thereby killing all the virus inside it. The cells can recover, that they can reproduce by mitosis of adjacent stem cells. They can recover. You'll have a sore throat or you'll be unwell for a little while maybe, but hopefully if it does this at a very early stage. See, if it does this, if it kills these cells when there's only a few hundred cells infected, then you would never know you had the infection. That's what they'll do. So hopeful for that, and we know that there is a T cell response, we just don't know how long it lasts for. So looking good. So trials are now being carried on, finished off, phase 3 trials in Brazil, India, South Africa, the UK and the United States. Ones are going again now, I'm pretty sure now, or if not are about to go again. Now, question marks of course over the safety of this vaccine. There was a person got inflammation of the spinal cord, but it's looking like that was probably not related to the vaccine, because people can get that anyway. Anyway, that's speculation, but what we do know, that the Medicines and Healthcare Products Regulatory Agency in the UK and the Food and Drug Administration in the US have both analysed this data independently and have both decided to resume the clinical trials, as have the authorities, we would assume, in Brazil, India, South Africa as well. So what we know is that that one and that one are both satisfied with the level of safety of this vaccine and are carrying on with the trials. So basically people need to guard until this vaccine is available if they're at high risk. So calculate your own risk and decide based on that information what your risk is, and based on that decide the level of guarding that you or your parents, for example, your grandparents might want to consider over the next few months, bearing in mind we are optimistic that high risk groups such as the elderly, such as those with comorbidities, could well be getting vaccinated in the UK, and the timescale is actually very similar in the US, early next year. I think that to modify lifestyle significantly over one winter to give you another 10, 20 winters after that is well worth considering. And if that means a few of you that have listened to this video all the way through are able to take effective action, and one person doesn't die this winter, as many will, if one person doesn't die as a result of this, it's been worthwhile and I will be delighted. Thank you for watching as always.